something like clinical examination of the child with heart disease, traditionally, that class is targeting the undergraduate student or the postgraduate student who is beginning a posting in cardiology. Of course, they need to know that. But I have always felt that it is possible to focus that type of a discussion differently, refining our understanding of congenital heart disease and the recognition of it. And that discussion can be refined to enhance our detection of critical congenital heart disease. This is particularly relevant when we are involved in a program where the early recognition of critical congenital heart disease is the key to the success of the program. Therefore, in your outpatient clinic, when you find a child and when you are seeing the child from the potential point of view of a heart disease, I would always say that the first thing to look for is the child comfortable or in distress? The importance of that, children come to us in all shapes. A given child waiting in your OPD or your emergency room may be critically ill with congenital heart disease. It is our duty to ensure that these children do not get lost in the total crowd that is waiting in the outpatient clinic. Therefore, recognizing the child in distress is an art, and we need to do that. Once you have confirmed that the child is not in distress, you have time to examine the child, you will go the pediatric way with anthropometry leading the list with height, weight, and head circumference. Each of this could have a bearing on a cardiac diagnosis also. We would like to see whether there is cyanosis or clubbing. We would do a head-to-toe examination for congenital abnormalities like abnormal fascias, limb anomalies, polydactyly, syndactyly. These things may be clued to specific congenital heart disease. But about the first point, the child in distress. If your child is tachypneic, the child is showing head bobbing. If the child has retractions, intercostal and or subcostal, if the pulses are poorly felt, if the child is tachycardic, all these are far more important for the small baby because in a bigger child, you will recognize these things readily. If you find one or more of a combination of these things, then what we should do has been dictated by PALS. Clinical examination should be fast and decision must be taken with regard to ICU admission and or ventilation. In this context, let us also recall what is the implication of a child who is dyspneic or the child who is having retractions. We know that dyspnea in heart disease may be either a manifestation of a left heart obstructive disease or a left heart dysfunction, or it's an evidence of hypoxia. When there is a left ventricular failure, or there is obstruction to the flow of blood into the left ventricle as in mitral stenosis, the left atrial mean pressure is raised and that is reflected in the pulmonary venous system. A raised pulmonary venous pressure results in a transudation of fluid into the pulmonary interstitium, and the baby now needs a greater respiratory effort to move the congested lungs. This is the process that we designate as dyspnea. Stimulation of the J receptors in the interstitium, which triggers increased respiratory center activity, is one of the pathogenetic mechanisms that is operating now. And when the baby has increased inspiratory effort without proportionate lung expansion, there is intercostal and or subcostal retraction. This is what happens to the baby with large VSD, worse to the baby with an obstructed TAPVC or cor triatriatum. You are finding manifestations of pulmonary venous hypertension. Something totally contrary is happening in hypoxia, where hypoxia, is a stimulant to the respiratory center, and an exercise-induced systemic vasodilatation causing tachycardia and the venous return causes desaturation, and the drop in PO2 becomes a stimulant for the respiratory center. Also, recollecting our understanding of cyanosis, we all know that it's a bluish discoloration of skin and mucous membranes. It is due to an increase in the level of reduced hemoglobin. We classify it as central if it is based on a cardiac or pulmonary cause, or peripheral if it is due to increased oxygen extraction at the capillary level. The peripheral cyanosis would disappear on warming the extremities. And the distribution of cyanosis should be noted. Is it uniform? Everywhere it's the same, or is it differential? We will refer to differential cyanosis in a minute. Cyanosis is often accompanied by clubbing. It's not present at birth, but is evident by 6 months if there has been cyanosis from the neonatal period. So if your baby is cyanotic, evaluation is in a different track. You would like to confirm that the baby is cyanosed by checking the pulse oximetry. And you know that in our pulse oximetry mandate, a saturation less than 94% should be considered as hypoxia warranting investigation. The baby has failed a pulse oximetry test. In recognizing whether there is a differential cyanosis, you look at the difference in saturation between the upper limbs and the lower limbs. 3% or more difference in saturation is significant. Baby has failed the pulse oximetry test. Then when you have a doubt as to whether the cyanosis is central or peripheral, if you keep the baby warm, if the cyanosis is cardiac, you can find that it is still present, while a peripheral cyanosis will disappear. The other question that confronts the pediatrician often is this a cardiac cyanosis or is it a respiratory cyanosis? Because a severe parenchymal lung infection is a reason for cyanosis. For this, the simple dictum that if the baby is peaceful and the baby is still cyanosed, that is a cardiac cyanosis. Think of the baby with transposition. The baby looks fine, saturation is low. Fine as in respiratory rate is a little on the faster side and the saturation is low, but there is no distress. Compare this with a baby in bronchopneumonia and desaturation. You will find that the baby has a lot of intercostal and subcostal retractions. Response to oxygen, something that all of you are familiar with. If you give 100% oxygen for 10 minutes to a newborn, if the PO2 increases to 300 or more, that is respiratory cyanosis. And if the PO2 stays below 150, that is cardiac cyanosis. And in a baby in cardiac cyanosis, if you're doing an ABG, you'll find that the PO2 is low, the saturation is low, the pH is low, and the PCO2 is also low. We refer to differential cyanosis. So if the cyanosis is more in lower limbs compared to upper limbs, you call it differential cyanosis. The implication is that the pulmonary arterial blood is perfusing the lower limbs. In a newborn, we refer to the value already. A 3% difference between upper and lower limbs is enough to call it differential cyanosis. In a newborn, persistent pulmonary hypertension is an important cause, but a duct-dependent systemic circulation is a very important cause. Example would be interrupted aortic arch or coarctation or hypoplastic left heart or critical aortic stenosis. In all these instances, duct in the day 1 or day 2 is patent and is perfusing the lower limbs. And therefore, the lower limbs have a lower saturation. In the older child, presence of differential cyanosis is practically pathognomonic for Eisenmenger PDA. This is look at the upper limbs and the lower limbs. Look at the fingers and the toes. You can find that the fingers are just marginally plethoric perhaps, but the Toes are clearly cyanosed, and you can see the clubbing in the toes. They're not present in the fingers. This is differential cyanosis and differential clubbing. We also come across this entity, reversed differential cyanosis, where the lower limbs have a higher saturation than the upper limbs. In the NICU, if you find this, do not ignore this as a mistake. It is an important observation. If it is your lower limbs that have a higher saturation than the upper limbs, it means that the PA blood, which is reaching the descending aorta, has a higher saturation than expected. It usually means that PA is coming from the LV, and that is what we call transposition. So in transposition, if there is a coarctation and a PDA, not an uncommon combination, it is the highly saturated pulmonary arterial blood which will go through the duct and perfuse the descending aorta. Result, reversed differential cyanosis. In this context, I would also make a reference to the baby in cyanotic spell. You know that cyanotic spell is a rapid decrease in systemic oxygen saturation with hyperventilation. If you don't check it, we are not able to interrupt the vicious cycle. The baby progresses to convulsions, coma, and even death. The key factor here is the combination of rapid decrease in saturation with hyperventilation. When a baby cries, if the baby had a cyanotic heart disease, the crying baby will have a drop in saturation. You do not call it a cyanotic spell. Cyanotic spell is a very, very serious situation, and the term should be used only if you find hyperventilation along with a rapid decrease in systemic oxygen saturation. Before your eye, the saturation is dropping from 70 to 20, and the baby is hyperventilating. That is what you would call a cyanotic spell. Typically seen at 6 months to 2 years, and it may be triggered by crying or exercise. What causes the spell? Think of tetralogy, which is the prototype for a condition causing cyanotic spell. When the baby is active or when the baby is crying, there's a drop in systemic vascular resistance, and there is a probable spasm of the infundibulum. As a result, the right ventricle pumps less into the pulmonary artery, more across the VSD into the aorta. As a result, there is a drop in saturation, acidosis, the drop in PO2 and the drop in pH are stimuli to the respiratory center. So there is a hyperventilation, and this becomes a vicious cycle because hyperventilation does not result in an increased flow to the lung. With these variations regarding a critically ill baby, let's come back to the quiet run-of-the-mill baby that you see in your OPD. So the clinical approach to such a baby would of course begin with your anthropometry. You will look for cyanosis clubbing, you will look for head-to-toe examination, you will look for any abnormal facies, limb anomalies, or something else that you may notice. Here again, remember that these values are giving you a reason to diagnose failure to thrive. Failure to thrive is a very pediatric problem, but failure to thrive also can be a manifestation of serious heart disease. I will not define failure to thrive for a crowd of pediatricians. I would only point out that in congenital heart disease, if there is congestive heart failure, feeding difficulty, and decreased caloric intake is a reason for failure to thrive. Increased catabolism as due to recurrent respiratory infections, systemic venous congestion causing a portal venous congestion, hence anorexia and poor absorption. All these could be the underlying mechanisms for failure to thrive in a child with congenital heart disease. Or it may be part of a syndrome like DGeorge or rubella or Down syndrome. And recurrent respiratory infections may be part of low immunity. This is the typical facies of DiGeorge syndrome. Look at the low set ears, the narrow palpebral fissure, the long face, the bulbous nose, and the long philtrum. And the conditions called conotruncal anomalies go with this. Typically, tetralogy, truncus, interrupted aortic arch. These are all examples of conotruncal anomalies. Or Williams syndrome, where there is the elfin faces, the funny face of magical creatures. Again, prominent forehead, hyperteliorism, an upturned nose, patulous lips, and if you find this face, you're looking for supravalvular aortic stenosis and pulmonary stenosis. Noonan syndrome and Down syndrome are some of the other common syndromes which could be associated with heart disease. And in Noonan syndrome, you have a dysplastic pulmonary valve with pulmonary stenosis, hypertrophic cardiomyopathy, or ECG may just show a left axis deviation. And in Down syndrome, you could get a AV canal defect, as you know, or it could be just a perimembranous VSD. You could have combinations like a tetralogy with an AV canal defect. With all this, the cardiovascular examination after the general examination proceeds as pulse, blood pressure, and JVP. So coming to examination of the pulse, some of it may be didactic, but looking at the pulse still continues to be an important way of recognizing anomalies in congenital heart disease. You know that the pulse is a pressure distension wave due to ejection of blood into an already filled aorta. It is propagated along the arterial walls, and it is palpable in all superficial peripheral arteries. So much so for the definition of a pulse. The components of a pulse are the percussion wave and tidal wave in systole and the dicrotic wave in diastole. The percussion wave is the impulse generated by the LV ejection. The tidal wave is usually not recorded, certainly not palpated. They are reflectance waves from the upper part of the body, while the dicrotic wave represents the recoil of blood from the closed aortic valve and reflectance waves from the lower part of the body. So if you have a pulse wave tracing like this trace could be from the descending aorta. You have a percussion wave, the tidal wave is not seen, and you have the dicrotic notch when the blood column is hitting against the closed aortic valve, and the wave that follows that is the dicrotic notch. So the second sound will come where this is marked, where the systole is ending. You know that to the students, we always say when you describe pulse, describe it as so many beats per minute, regular, normal volume, normal character, no radiofemoral delay, and the peripheral pulses are normal. Otherwise, describe the abnormality in each one of these headings. Abnormalities of rhythm, we could have irregular rhythms like bigeminy, trigeminy, or atrial fibrillation. Abnormalities of volume, let's remember what is the volume? It is the amplitude of the expansile movement of the vessel wall. You need to describe it as normal, low, or high. And we know that the pulse pressure is the measure of the volume of the pulse. A low volume pulse in the OPD is a serious situation. It denotes low output state, severe aortic stenosis, or severe pulmonary hypertension. A high volume pulse denotes in a child conditions like a patent ductus arteriosus, truncus arteriosus, aortic regurgitation. In an older child or adult, it may denote some of the simpler things also. In an adult woman, this may happen in pregnancy. In any child in fever, the pulse is of higher volume. And some major abnormalities of the volume of the pulse would include the pulsus alternans and the pulsus paradoxus. The pulsus alternans means the alternating pulse beat has a lower volume. It happens in severe left ventricular failure. It happens because in severe left ventricular failure, especially when an ectopic beat happens, that ectopic beat doesn't elicit contraction of the entire complement of heart muscle. That volume is low. Once the rhythm has recovered and it's still normal, it is still in sinus rhythm, alternate beats continue to elicit contraction only of a part of the left ventricle, and they are of lower volume. So this alternation between a low volume pulse and a high volume pulse signifies severe left ventricular dysfunction, and that is called pulsus alternans. Pulsus paradoxus, on the other hand, is an exaggeration of a normal phenomenon. In severe asthma, for instance, the inspiratory holdup of blood in the inflated lung causes less blood to return to the left heart. And as a result, you find that the pulse volume is lower in inspiration. In heart disease like constrictive pericarditis or pericardial effusion, this happens in an exaggerated way. Up to 10 millimeters of drop in inspiratory pressure can be normal. A systolic pressure can be normal. But if in inspiration, the systolic pressure drops by more than 10 millimeters of mercury, that's an important thing. And the cardiac conditions where this may happen include cardiac tamponade and constrictive pericarditis. Status asthmaticus can also do it with a normal heart. That was volume of the pulse. The character of the pulse, we refer to a collapsing pulse, which is a high volume pulse with a rapid upstroke, ill-sustained peak, rapid downstroke. And you know that it is associated with it is appreciated with the distal palm when you elevate the arm. Causes are again hyperkinetic states that we refer to in the causes for high volume. Important conditions we need to think are PDA, aortic regurgitation, aortopulmonary collaterals, truncus arteriosus, a BT shunt. These are all conditions where you can have a collapsing pulse. We also speak of the bisvariance pulse when you can feel 2 beats on the upstroke. It can happen when aortic stenosis is combined with aortic regurgitation. In children, a bicuspid aortic valve is a commonest reason for the combination of aortic stenosis and aortic regurgitation. Or chronic severe aortic regurgitation alone can be associated with a bisvariance pulse, or hypertrophic obstructive cardiomyopathy, rare in children as a full-blown hypertrophic obstructive cardiomyopathy, but if it is there, that can also be a reason for a bisvariance pulse. If you can look at these images, they would show you what is the different pulses. Here you can find the normal pulse with its dicrotic nodes and a pulsus alternans where the alternate beats have a lower volume. A pulsus bisvariance, this is the double beating pulse. The dicrotic nodes is different. In systole, you have 2 beats. And a pulsus paradoxus where some beats have a lower volume, and you can see that the lower volume pulses are happening in inspiration. In the past, we used to speak of a dicrotic pulse in toxic fevers, the slow volume, low rising pulse in aortic stenosis, the anacrotic pulse when there is a shoulder on the aortic nodes. These things may not be recognized easily. They're essentially when there is an arterial trace. So once you have recognized these attributes of the pulse, you are feeling the peripheral pulses. It is important that you inculcate in students the practice to palpate the lower limb pulse when they are feeling the radial pulse. If you have a hand on the radial pulse and the other hand on a pedal pulse, I do not say femoral, I would say pedal. In the pedal pulse, you will readily pick up abnormalities of peripheral pulses. Why I don't say femoral pulse is because in an infant particularly, if you insist on feeling the femoral pulse, the baby may not allow you to do it, and the baby will withdraw the thigh and may become uncooperative. If you have felt pedal pulses and if you know that it is normal, you don't have any concern regarding coarctation. When you feel both radials and both pedals, there are several things that you can recognize. If there is an asymmetry of the upper limb pulses, say you have a right radial which is well felt, but the left radial is not felt. If there is a coarctation distal to the left subclavian, in other words, involving the arch, this is likely to be seen. In Takayasu arthritis, this may occur, or congenitally, the right subclavian may not come as part of the innominate, it may come from the descending aorta, in which case that long course causes it to be compressed and the right subclavian, the right radial pulse is feeble. There is also the interesting condition called isolation of the left or right subclavian. This means that it usually happens in tetralogy. There is a duct and the subclavian is a continuation of the duct. So it can be a continuation of the left subclavian from the duct or a right subclavian from the duct. The affected side has a lower pulse volume. In supravalvular AS, the right upper limb has a better, higher volume pulse. It's called the Quanta effect. It's related to the way the jet goes. So if you have a right radial more than the left radial, Quanta effect, supravalvular AS. If you have a feeble right radial with evidence of coarctation, it means that there is an aberrant right subclavian. If the left radial is feeble in coarctation, the coarctation is pre-subclavian. If you have a tetralogy with a feeble radial, a ductal origin of the subclavian is a possibility. But please remember, if that patient had a VT shunt, on that side, the pulse volume could be lower because the subclavian could have been compromised in the VT shunt. And radiofemoral delay is elicited by simultaneous palpation of radial and femoral pulses, and you find that the femorals are absent, feeble, or delayed. It commonly denotes coarctation of aorta, but aortoarthritis or other causes of arterial occlusion may also be considered in this context. Recording blood pressure is something that we do on a daily basis. So I would only highlight the potential fallacies in what we record. One, very few outpatient clinics have a range of pediatric cuffs for sphygmomanometry. And if the cuff size is not appropriate, the recorded blood pressure is not going to be reliable too. In the past, we used to do the flush method for recording the mean BP in neonates. But today, we would use the oscillometric technique and record the non-invasive blood pressure. But I always tell my pediatrician friends, I have greater faith in your fingers than in an NIBP reading. The NIBP reading is as vulnerable to the errors of blood pressure measurement, perhaps more, as is a sphygmomanometry with a pediatric cuff. So if your readings are totally out of context, feel the pulse, assess the pulse volume with your fingers, that may be more reliable than a number that you see on the monitor. You know the different phases of Kuroko's sounds. From the pulse and the blood pressure, you're looking at the jugular venous pulse. You would think that in pediatrics, this does not have much significance. Of course, in small infants, it has no relevance at all. But in the older child, with a visible proper length neck, looking at the JVP can certainly be helpful. And in such children, in older children, you will measure it in the right internal jugular vein, and it reflects the right atrial pressure. And in infants, the equivalence of a raised JVP is obtained by palpating the liver. The liver readily gets enlarged in an infant with right heart failure. Among the waves, you know that the A wave denotes atrial contraction and the V wave denotes ventricular contraction. The X descent is the tricuspid valve descent with RV systole. The Y descent is the RA emptying with tricuspid valve opening. And the H wave, not commonly seen, shows passive filling of RA. If you look at this cartoon, this illustrates what happens during each phase of cardiac cycle on the jugular venous pulse. Look at the lower part first. What's happening here? The right atrium is contracting. Of course, the left atrium is also contracting. But what we are seeing is what happens on the right side. When the right atrium is contracting, the JVP elicits a wave called the A wave, A or atrial wave. After that, so A wave is in the very end of the diastole. After the A wave, you have a C wave, which is because the tricuspid valve is descending towards the apex as systole begins. So you have this small shoulder called C wave. It is there in a recorded trace, but you're not going to see it ordinarily. Now, following the C wave, you get a descent. You get a descent which is called the X descent. That X descent is because the tricuspid valve is descending, and the atrium is then relaxing. It is no longer contracting. The tricuspid valve is descending, and the X descent is happening. The C wave is also attributed to the knock on the carotid, knock by the carotid on the jugular venous pulse. Because as systole begins, as ejection begins, the carotid starts pulsating, and the distension of the carotid may be affecting the jugular venous pulse and eliciting the C wave. The X descent is due to the tricuspid valve descent. Then, as the atrium is relaxing, it is slowly receiving blood from the vena cava. The pressure is slowly coming up and recording the V wave. So once the V wave is inscribed, the systole is about to end and diastole is beginning. As the tricuspid valve is opening, pressure rapidly drops, and that elicits the Y descent. Now, as the Y descent progresses, at later point in diastole, the atrium is contracting and the next A wave comes. So this is how the different cycles are related to events in the jugular venous pulse. I would only say that some parts of physiology in relation to the jugular venous pressure are still relevant in children. Think of prominent A waves. They are atrial contractions. So to recognize that it is a prominent A wave, you have to feel the carotid, and the A wave is felt just before the carotid pulse is felt. It is pre-systolic. So a prominent A wave may be seen with severe pulmonary hypertension, especially if the ventricular septum is intact. You get a prominent A wave. In a severe pulmonary stenosis, it's after all high right ventricular pressure, which is the reason for the prominent A wave, because this causes right ventricular hypertrophy and makes the RA contract stronger, more forcefully to fill the RV in diastole. If there is a tricuspid stenosis or tricuspid atresia, you may get a prominent A wave. As against a prominent A wave, you may have a cannon wave in complete heart block. Cannon waves are systolic A waves, systolic. The normal A wave is pre-systolic. Cannon waves are systolic A waves when atria are contracting against closed AV valves. In complete heart block, atria are contracting at a rate faster than the ventricles, and there is no relation between the two. So some chance A waves would fall on a closed tricuspid valve, and the result is a cannon wave, which is a systolic wave which leads to your attention. The cannon waves are irregular in complete heart block. In some tachyarrhythmias, like a junctional tachycardia, where the AV node is responsible for capturing the atrium, in some cases, you may get regular cannon waves also. So prominent A waves are pre-systolic waves seen when there is a right ventricular hypertension and right ventricular hypertrophy, causing the RV to be stiff. RA contracts more forcefully to fill the stiff ventricle. Or the cannon A waves are not pre-systolic waves. They are not big A waves. They are systolic A waves which lead to your attention when the atrium contracts against a closed AV valve. Prominent V wave, it means something more is happening in the atrium than simple passive filling. It actually involves an active pumping of blood into the RA, as is happening in tricuspid regurgitation, or in an ASD with mitral regurgitation, or when there is a shunting from LV to RA. So that is all prominent V wave. In Kussmaul's sign, there is an inspiratory rise in the JVP, which is seen with constrictive pericarditis. So in JVP, if you ask me in children, what things should you keep in mind? An elevated JVP should be looked for in an older child. If you find that the JVP is elevated or if a wave is prominent, try to identify which wave is prominent. You can do that by putting your finger on the opposite carotid. What you feel with that carotid is a V wave. What you feel prior to that carotid is an A wave. If there is a prominent A wave, it helps you in assessing the severity of the cardiac lesion that you're going to diagnose. For instance, if your diagnosis is valvar PS, and if there are A waves, it is definitely severe PS. Or in PH, a pulmonary hypertension, a prominent A wave is a sign of at least systemic levels of right heart pressures. So once you have seen and prominent V waves in conditions like tricuspid regurgitation and LV to RA shunt. Once you have seen pulse, blood pressure, JVP, this is the order in which we are progressing. We are progressing to examining the chest. You would look at the shape of the chest because we know that it can influence the position of the apex beat, whether it a pectus excavatum or carinatum or kyphosis or scoliosis. Any of these can influence the position of the apex beat and make you think that the heart is large when it is not necessarily so. We would also look for surgical scars like a median sternotomy scar or thoracotomy scar. It gives you an idea as to a type of procedure that the child has undergone in the past. There are other pulsations that you could look for. If there are prominent left parasternal pulsations, that means that there is a right ventricular volume overload. And left parasternal pulsations may extend up to the apex in an atrial septal defect because the apex is formed by the right ventricle. If you have localized pulsations in the left second space, it means the pulmonary artery is enlarged. If you have epigastric pulsations, it denotes RV enlargement. Pulsations of the whole of the precordium in late systole happens in severe mitral regurgitation. This can be easily confused with the left parasternal heave. The left parasternal heave, elicited by keeping the side of your hand on the left parasternal region, is a sign of RV pressure overload, as in pulmonary hypertension or in severe valvar PS. You may find rippling pulsations across the sternum in Epstein's anomaly. And systolic pulsations to the right of the sternum is a feature of aortic aneurysm, which may happen in Marfan syndrome. So pulse, BP, JVP, you have looked at the precordium for any pulsations, and then you try to localize the apex beat. The apex beat is the lowermost and outermost point of definite cardiac pulsation. The normal apex beat will lift the palpating finger, but that lift does not take it beyond the level of the adjoining ribs, nor is it sustained for more than a third of the duration of systole. These two are the defining features of a normal apex beat. One, it is localized to one space. Two, the palpating finger is elevated slightly, but not beyond the level of the adjoining ribs. Three, the duration of systole for which it is sustained is less than a third of the total duration of systole. So these are the features of normal apex beat. We like to describe an apex beat as normal, tapping, forceful, heaving, or double or triple apex beat. A tapping apex beat is one where the first sound is palpable over the apex beat. A very distinctive feature of mitral stenosis. And a forceful apex beat is one that lifts the palpating finger beyond the level of the adjoining rib for more than a third of systole. Remember the normal apex beat definition? It does not go beyond the level of the adjoining rib. It does not go more than a third of the duration of systole. If both these limits are exceeded, you call it a forceful apex beat. If they are not only exceeded, but it is sustained for more than half the duration of systole, you call it a heaving apex beat, which is a sign of aortic stenosis or hypertension. If an additional event is palpable over the apex beat, as a palpable fourth sound, it becomes a double apex beat. In hypertrophic cardiomyopathy, we speak of a triple apex beat, because there is the apex beat with the fourth sound, plus the apex beat is split. When the LV is pumping across the obstructed infundibulum, the obstruction comes later in systole. Therefore, you have the earlier apex beat, then as the obstruction comes, a more pronounced heaving touch to the apex beat, and there is a presystolic pulsation, which is the S4. From here, we are going to proceed to auscultation. But I would separate auscultation for another class, and would like to take any questions from you here before I leave you today.